Hi, Dr. Katz.
Hey, how are you?
Good, how are you?
Good. Can you hear me okay?
Yeah, nice background too.
That's as creative as I get.
Yeah. Thanks for doing this kind of last minute. I know they had to switch some judges around, so we appreciate it.
Oh, that's okay. No, I was a little jealous that others were going to get to do it anyway. So
Yeah, it's always fun. First time we're doing critical care though, so we're excited.
yeah, that's good. It's nice to be brought to the grown-ups table.
Yeah, right? It's a
Mhm.
very hot topic right now, so we thought it was very timely.
Yeah. As someone that sat on the kids' table for a long time till I think I was out of college, it's I recognize the privilege.
Hi, Dr. Bohula.
Hi, Alexandra.
Hey,
You
Erin.
can hear us well?
Yeah, I can. Yeah.
Perfect.
Hey, Jason.
We're gonna just,
Hey.
if anything pops up, I'm leaving everyone in the lobby that's not part of this little special group. So you guys can ignore that.
Great.
Hey, everyone.
Hey, guys. Hey, Dave.
The shark is perfect.
Isn't
Although
it?
on the, I must say, close to Cape Cod now, it's all too scary and real. So
Yeah, is that right?
yeah, no, we've had a bunch of shark sightings. We keep seeing, teenagers with big holes in their legs on the news. It's
God.
terrible.
I should have had a
All
friendlier
right,
shark then.
so maybe just because we don't have a ton of time to preview, um, for how we approach it, I'd say that I'd be a little concerned that with the very concise timeline, just the 2 minutes, that it will be hard to fit in some meaningful feedback and questions and develop the sort of shark repartee with the contestants. Certainly, Steve is welcome to lob things at Jason anytime. But I think I don't know. Do you guys agree? Or Erin, you've done this directly. You too, Jason. What do you guys think?
Well, I've actually never done it, to be honest with you. I think just
Yeah.
Erin.
Oh, then what do you think?
We could do it in 6 minutes and just do it in order. Right, as opposed to 2 and 2 and 2, we could just say, you start, and then Dave, you could come in and say,
Yeah, that's what they've done in the past. The first one kind of just says what they want, and then the other two had similar comments, so they just kind of add a couple things to it. And that's why we changed the rotation of the judges each round.
And that's actually kind of how it had worked before. It was Carlos, Jake, and myself, and definitely the first person who spoke tended to speak longer, and then the other people would kind of say, "Yeah, no, I agree," and I have this one other thought.
And that sounds totally fine to me. I guess. Yeah, go ahead, Steve.
So I mean, we're gonna think about it in 6 minutes, and somebody will start, and you can. If it's somebody's, when I start blathering on at 3.5 minutes, you shut me up and call on Jason.
Yep. Yeah. No
yeah, and it's
problem.
just kind of your initial thoughts too, and then you guys will have a full 5 minutes at the end to talk about all three of them together. It's just kind of your initial thoughts to the presenter right after they speak.
Sure.
Yeah, and I think we'll skip asking them to make an offer. I think that just probably won't work for this format.
Definitely something we can think about for ACC 24 when we do a live one, but
yeah.
But I still don't understand how it works, because we're giving the money to them, not the other way, right? They're and they don't want to piss off any of us. We're all voting, right?
Yeah. Well, we did before. I mean, there was somebody who was a winner, but we just also sort of offered up our services, in one way or another, and we sort of said what we could do to help them or support them, and then they kind of said, yeah, I'll take it from you, one of three, and then anyway, so that was kind of, so it just added an element of like, it definitely increased the banter among the judges, right? As you were kind of like, well, I can offer this. And then the other judge was like, yeah, right. I mean, it was just there was a little more back and forth, I think, maybe because of that, but
we're buying from them. It's like, if you give me half the money, I'll write half your paper.
No, I think, Steve, your email was well taken, and maybe at the live format we'll do we'll go back to that more Shark Tank like feel. But I think here we'll spend 6 minutes on each. We'll let the first person kind of take the yeoman's role on that, and then make sure everyone chimes in on each.
And then the winner of this participates in the ACC 24 Shark Tank.
Mhm.
Okay.
Yeah, we have this one, and then we're doing an interventional heart tank and imaging. So the winner of each
Yeah,
will do
wow,
a
okay.
final showdown.
But
Nice.
just to be clear, we are allowed to ask questions of the presenters.
Yeah.
Yeah.
Absolutely.
During our 6 minutes.
Yep. Because what will happen is the winner, they'll end up presenting this same piece of research and hopefully take into consideration some questions and advice you guys give them.
Sure.
Yeah, I mean, 6 minutes will go quick, right? If we're able to have a bit of a back and forth with them.
Yeah.
It will, but I think the point is very much for you to ask some probing questions, because I think it will both help you in your judging, but I think we're really trying to stimulate them to think about things in their project they might not have yet. So I think that's definitely part of it.
Great.
But also I do think, if one of them freezes up and just, gives us the, particularly we got a
sure.
resident,
Yeah.
if we get the deer in the headlights, one or the other one can jump in and say, well, I'm going to answer it for him. The way to do that is.
Yeah, exactly. And Dr. Murr, you're good. You don't need anything in terms of introductions. You have kind of your script there.
I do. I have everything. I think my only question for you was, is there anything in particular that you want me to say about the program other than what's in the overview?
No, I think that's perfect. And I'll just, as soon as we start at the top of the hour, I'll just give a brief intro, welcome everyone, and then I'll turn it over to you to do, take it from there. So I have all the slides. I'll run all those. That way we don't get caught up with them trying to switch their screen and take more time. So I'll run all
Okay.
that.
Perfect.
And just so the 3 judges know, I do have a breakout room set up for when we do deliberate. So I'll open that up when it's time, usually around like 7:45, 7:50 is when we end with the 3 and all the questions. So you'll see a breakout room pop up, and I'll have you guys join that and then come back in.
And Alex, it seems self-evident, but I'll stay in the main room and field questions
Yes.
from the
Yeah.
audience.
Usually we have questions from the audience come through, and the FITs will kind of discuss them. But if you want to moderate them and answer some, yeah, that's perfect.
Sure. All right. Sounds good.
So I'll probably give it a few minutes until I open the lobby, just so we're not all hanging with
Yeah.
them.
Yeah.
So feel free to take a few minutes, and then we'll pop back in soon.
Great.
All right. Sounds good, team.
I got 7 minutes to figure out how to get a background.
Yeah.
More importantly, Erin, how's the baby?
Oh, he's good. He's about 5.5 months. He's amazing.
5.5 months already. Oh,
Wow.
Yeah, I know. It goes quick, right? Yeah.
God.
Yeah, he's great. He's easygoing. It's a chill
Awesome.
baby, so we're lucky. Yeah.
I
He'll
have
be in
2.
college before
This
we
is
know
number
it.
3. Is that right?
Yeah. That's incredible. I'm impressed. You know that. Yeah, I have a 10 and a 7-year-old, and then this guy. So it was had to relearn everything.
Have diaper genies advanced in the last 7 years?
I'm sort of feel bad even saying this, but we still have our diaper genie from before, which is incredible. But we also it still works, and then we got another one. So
Comes
and
with
the
a
ones
lifetime
now,
guarantee, I bet.
yeah, and the ones now are better because you can use regular bags.
Yeah.
Wow, that's a major advancement.
Right? Yeah, you don't have to buy those
Yes.
inserts.
My youngest is 23. It's been a while since I had one.
How many do you have?
2.
2.
There's a 25-year-old's a 4th-year medical student, and the 23-year-old just graduated with her MPH last week.
Oh, cool. Congrats.
That's awesome.
Very cool.
And she has a job.
That's
Nice.
Even
more
better.
awesome.
Yeah.
Doing what?
She's doing, it's a public health, she got an MPH, and she's working for a company that does data analysis and interpretation in the public health field.
Nice.
Collecting epidemiologic data and repackaging, interpreting it, and repackaging it, and stuff like that. That's what I
Wow.
think she's doing. She'll tell me I don't really understand what she does. She'll also tell the daughter in medical school and I that we're missing the boat. We take care of people one at a time, whereas she sees the big picture and prevention. And she's not entirely wrong, although there is some value in taking care of people one at a time, I think.
It's necessary, right?
A little of
Yeah.
both sides, right?
Yeah.
Yeah.
Dave, is it official? Has she decided where she's going to college?
No, because we're still on a waiting list.
Right.
So we'll see. But
Okay.
at the moment, University of Wisconsin is
Oh, you have someone graduating right now, Dave?
yeah, my eldest Sarah is
My twins are graduating this
oh
year
my
too.
gosh.
Yeah.
Oh, I don't envy the twofer.
Yeah, and one then the third will be a senior this year. So
That takes
she'll
some
follow
financial
them.
planning.
So,
Yeah.
so Dave, if you don't mind asking, what's your daughter waiting on?
Yeah, so she my alma mater, Georgetown.
Ah,
So we'll see if she ends up getting
Hmm.
into Georgetown. But she really loved Wisconsin too. So either way, it's a win. But we'll see. I'd still rather drive her to DC than Mass.
I remember going there and told me there's an elementary school where they speak 52 different languages.
I believe it.
Yeah.
Wow.
It's amazing. It is such a college town. I grew up in Evanston, which is where Northwestern is, as you guys probably know. And so, I mean,
Yeah.
it has that sort of same feel. It's just dominated by the college, which is a great place to go to college. So.
My kids were born in Evanston Hospital.
Oh, awesome! I didn't know that, Steve.
Yeah, I was in Chicago when they were born.
Yeah, no, I grew up in Evanston, and then we moved away for a while, and then ended up back. I love that area.
Yeah, that's great.
Aaron's a
I'll
Chicagolander
probably,
too.
you guys good if I open it up?
Yeah,
the
because
rest of the-
I think we'll want to start on time, so it's absolutely
Okay.
fine for us to
It looks
be.
like one of the FITs is here too. Hi, Dr. Fry. And I'll just make sure that they're obviously popping in as we get
Oh,
closer to the
hello.
top of the hour.
Hey
All
there.
right, so let me go ahead and save that.
Great, and I'll just say for all our young investigators who'll be presenting today, we'll give each of you an opportunity to introduce yourselves as you come on. And then we do absolutely need you to keep to time. We'll have to automatically switch over the slides to the next presenter after 6 minutes.
Perfect. I see a couple. We have two of the FITs. I'm just going to see if I can or mute this sound that we're getting. Because we have a good amount of people signed up, which is great, but we don't need to hear that.
think it's hard to make that ding go away if it
I
wasn't in
know,
the initial setup. I think.
now that it's set up, yeah. I wonder why usually we can have them bypass the lobby though. Everyone. Hi, Dr. Harmon. Let me make sure you can unmute as a presenter. Give me 1 second.
Can you hear me now?
Perfect. Yes, we can.
Perfect.
And just so the FITs know, I will be advancing the slides. I have all of your copies. So just to make it more streamlined, and you guys can just say next as we go through them.
Okay.
But maybe for the sake of time, Dr. Morrow will probably go ahead and get started. Let me just go ahead and record. Looks like we already are. Perfect. So welcome everybody to the Heart Tank for the Cardiovascular Investigator. Tonight we are focused on critical care cardiology, and we are extremely excited to have Dr. David Morrow as our moderator tonight. And we have an esteemed panel of judges. So I will go ahead and turn it over to Dr. Morrow, and he will give you some more information.
All right. Good evening, everyone. As Alex said, I'm Dave Morrow from Brigham and Women's Hospital, where I'm a critical care cardiologist, and I welcome you all to this Heart Tank. As you all know, this really is an extension of the ACC mission to help develop all of our trainees as young investigators, and to give you the tools and the support that you need to do that. This Heart Tank for the Cardiovascular Investigator is intended to be really an informal, friendly platform to discuss methods of clinical research with an emphasis on techniques to help all of you have the tool set to conduct scientific research in this important area of critical care cardiology. And we have 3 fantastic trainee proposals that were vetted initially by the Academic Council to Educate from the ACC and have been selected to present to our esteemed judges this evening. I will introduce them. I know all of them very well. It's my great pleasure to do that, but I am going to read from their brief introductions just so I don't miss anything. Dr. Erin Bohula is an assistant professor of medicine at Harvard Medical School. She is a critical care cardiologist in our cardiac intensive care unit at Brigham and Women's Hospital. She's also an investigator with the TIMI study group and was one of the founding members of the Critical Care Cardiology Trials Network that is run out of TIMI. She received her bachelor's degree from the University of Chicago, PhD from Oxford University, and her medical degree from Harvard Medical School. She trained at the Brigham throughout her training, where I got to know her extremely well. But she has emerged as a leading investigator in this field and has been particularly interested in developing innovative and entrepreneurial approaches to research in critical care cardiology, and is really looking forward to giving you feedback on your design. Jason Katz is one of the forefathers of this field. He's an associate professor of medicine at Duke University in Durham. He was educated at Rice and then University of North Carolina, then trained in internal medicine at UT Southwestern, followed by cardiology and critical care medicine at Duke. He was a medical chief resident at UT Southwestern as well, and then completed a master's of health sciences in the clinical research program in a NIH Duke collaborative clinical research training program. He's board certified both in cardiovascular medicine and in critical care medicine, and in advanced heart failure, and has been a leading force in bringing those 3 domains together, and has been particularly interested in how we implement approaches and frameworks for caring for patients with critical illness in cardiovascular medicine. And we're very lucky that he gave up his dream to be a game show host and join us here in cardiovascular medicine and critical care cardiology. And then lastly, Steve Hollenberg, who is a professor of medicine at Emory University School of Medicine, where he directs the cardiac intensive care unit at the Emory Heart and Vascular Center. He started in Amherst College and then trained at Emory University School of Medicine, and then on to New York Cornell Medical College and in critical care medicine at the NIH, as so many in this field have trained. He spends much of his time now, as he tells me, taking care of his sheepadoodle tally, and maybe we'll hear a little bit about that during this session as well. So I want to go ahead and give most of our time to our presenters, and I'll go ahead and ask our first presenter from Mountain View Hospital to introduce yourself and take us through your 6-minute presentation.
Hi, my name is Berina Aslanai. I'm originally from Chicago, but I'm doing my residency here in Las Vegas, and I'm a PGY2.
And Berina, if you can, your camera isn't on, so if you are able, it'd be terrific to do that. There you go.
So today I just wanted to go over advanced parameters to manage patients in the ICU, basically. Next slide. So we already have well-validated parameters such as afterload, preload, and cardiac output. But when it comes to assessing left ventricular contractility, this is an area we're sort of stuck in. So the true measure of LV contractility is done in the cath lab. We could do it with an echo, but with an echo, it's not a reliable index of cardiac contractility because of how dependent it is on cardiac load conditions. So we attempted to look at other studies looking at differences in dP over dt, and mostly literature had it in regards to mitral regurgitants. So I think it was Barrow who initially looked at MRDP over T in intra-op setting, and he attempted to basically compare outcomes in the cardiac cath, or compare these outcomes intra-op to those in the cardiac cath, as well as with other methods of trying to find LV dP over dt. So it was I think it was Jay Zhang, who also did a similar study, and almost all of them had significant correlations with the LV contractility, and they were all significant without any confirmed changes. So the last one for Lee, so using a pig model, this study attempted to compare LV contraction with radial and femoral dP over dt. And this finding in the pigs had similar ones to that of Barrow's study. Next slide. So using dynamic arterial elastance, this is a ratio between PPV and SVV. So for this one, we use it to measure afterload, and the cutoff value in literature is typically 1. So value greater than 1 would mean that a patient is pressure responsive, meaning not only would their SV increase to fluid administration, but so would their MAP. And a value of less than 1 would mean that patient is fluid responsive, and we usually use it to help us wean patients off of vasopressor support. And next one. So the hypertension prediction index, it's relatively new. It was introduced by Edward Life Sciences in their Acumen software. So for the HBI, it's used to predict the likelihood of hypotension, and it's in a range of 0 to 100, with higher values meaning greater likelihood of instability. So we were able to find at least one study looking at patients undergoing elective non-cardiac surgery, and using HPI just for hemodynamic monitoring. And for this one, it was compared standard care versus HPI, and it was patients in the HPI group who noticed a 75% reduction in the duration of their hypotension. So the HPI group had hypotension for 8 minutes versus those in the standard care group, which had it for 32.7 minutes. Okay, and next slide. So why is this important? Well, if you look at the advanced parameters such as afterload with EA dyne, contractility with DP over DT, and the preload, afterload, and contractility, we're able to improve patient outcomes. So if we look at these trends, and so we're not looking at the numbers for DP, DT, we're just looking at the trend. So if we're able to follow the trend, we could act before a patient becomes hypotensive. Most of the studies we found are done not only overseas, but mostly intra-op. I couldn't find any that were done in the ICU. So by allowing the clinician to figure out the etiology of the patient's hemodynamic instability or their likelihood of hemodynamic instability and acting before the patient becomes hypotensive, we could theoretically reduce incidence, duration, and severity of hypotension. Less patients would have AKI and hopefully a shorter length of stay. And the next one. So these parameters that were once used just in the cardiac cath can be reproduced. And
30 more seconds.
our study design would be a randomized control trial, and our goal would be to compare outcomes, so including the basic ICU metrics. So using the Acumen software, we're able to follow the algorithm on the right. And we would use cutoffs for DP over DT, with the 600 meaning less than 600 mean worse outcomes, greater than 1200 meaning normal, with in between indicating LV dysfunction. Next. So anticipated outcome using the aforementioned parameters would be total fluid administration would be less, time to achieve hemodynamic stability would also be shorter, and their ICU length of stay would also be shorter. Limitation with this study is that if any patients have ventricular arterial, what's it called? Ventricular arterial decoupling. So it's like patients with aortic stenosis and peripheral vascular disease. It's very difficult to come up with a parameter. So I mentioned the 600 to 1200, but with these patients, I couldn't find anything in the literature to even give us a ballpark of the parameters we would use with these patients. And I guess the HPI algorithm that was in the previous slide, it would be difficult for these patients because that algorithm was based only on patients in the OR, because so far that's where all of the studies have been done.
All right. Thank you very much for that first presentation. We're going to go ahead and hand it over to Dr. Bohula to introduce our discussion period.
Great. Well, thanks so much, Florina, for going through that. If you don't mind, I might ask a question or two just to fill out a few of the details for me in terms of your design, and then I can give some feedback. But in general, of course, I love having hemodynamic metrics, and I love having continuous measures, and I love having things to target. So I like in general the strategy that you've outlined. You said you want to do a randomized control trial. Can I ask you, what are the arms that is it single arm? Is it sort of historical versus introduction of this HPI and all the other metrics, or what were you thinking about for the randomized arms?
So using standard of care and then the introduction to HPI, we're about ready to introduce it to our hospital. Mm-hmm. And it'll be interesting to see, I guess, the come out of it, just because I've noticed, I'm a PGY2, so in my 2 years, I've noticed that when it comes to fluid administration, it's mostly on the residents and the nurses to decide, because there's one attending for like 20 patients. So if we're able to allow the nurse as well as the residents to learn and understand the algorithm, it could improve outcomes, because oftentimes as soon as a patient becomes hypotensive, our first thought is, oh, fluids. But if we follow the algorithm, we'll know maybe it's not fluids, maybe they're in a vasoplegic state and they just need vasopressor support.
Okay, and so then you're saying you have some people who would be randomized to using this HPI metric and algorithm in terms of treatment, and some people who would be usual care. And then it's a protocolized management from there. What, you know, when you see a number that is X, you do Y.
Right. So we always encourage the protocol. The thing is, sometimes with, I guess, more educated individuals, especially anesthesiologists, they don't always follow the protocol, meaning that they're not going to look at the HPI number. They're going to go with their own judgment. And that's
Imagine
fair.
that.
It's understandable. That's fair. We're not treating the number, but they should still follow the trend and the value. But yeah.
Dr. Hollenberg, maybe I'll give you a chance to see if you have any follow-up questions.
Yeah, so there are a couple. I also love hemodynamics. I like the fact that you invented an algorithm for management. I guess I have a technical question and a trial design question. So I worry a little bit about frequency response. DPDT is fast. And now you've got it. You're essentially trying to measure this at the end of an arterial catheter in the radial artery. So do you have a sense of the frequency response of this for DPDT with the device in the artery?
So the DPDT is reproduced every 20 seconds. So the machine, it will give you a signal. So once the HPI is over 85, it'll give you a signal. Once that happens twice in a row, you get a high alert signal. Sorry. And then just using that, you're able to follow DPDT. So as often as the HPI is shown, so is the DPDT.
Yeah, I guess I worry a little bit about a black box number. You know, the number comes out and, 84 is not good and 85 is. It makes me worry a little bit. The other question I had about design, it's who are we selecting for this trial? Is this anybody who shows up? Is this anybody who's randomizable? Are we restricting this to a certain sort of patient?
So for this, obviously patients not undergoing cardiac surgery. For that one, honestly, I was just thinking ICU patients, but I only excluded those with open heart surgeries.
So I worry about that a little bit because there's a possibility if you pick people who aren't sick enough, you won't show a difference with a management strategy. If you pick people who are too sick and they all do poorly, you won't show a difference with a management strategy. So you kind of have to get the Goldilocks in between. And you might want to think about that. If they all have completely different conditions, and you've clearly defined the fact that the OR is a controlled thing, they're all having the same operation. Bypass patients look a lot like other bypass patients. And so trying to bring this to a general CCU, you might have to think about how to get that population a little clearer defined. Yep.
Is an excellent point, and I'm going to give Dr. Katz a chance for just one final wrap-up point or question.
Great, I'll be quick. That was an excellent presentation. I'm a simple guy. I didn't get my PhD from Oxford or anything like that. I ask simple, sort of practical questions. I can tell you it is far from simple operationalizing a randomized controlled trial in our contemporary cardiac ICU. You see people here on this call like Dr. Morrow and Bohula and Hollenberg who have been trying to do that among critically ill populations in the cardiac ICU for a while. Did you think about, given the fact that there's not a lot of great data in the contemporary cardiac ICU or among patient populations that we see in that ICU, of just doing more of a sort of an observational study where you try to capture this data on a select patient population? You don't dictate or randomize the patients. You don't dictate an algorithm or a plan, but just to try to accrue more data in this particular patient population to assess its sort of reliability and reproducibility.
So I'm going to ask for a very brief answer to that. Just yes or no, observational, and then we're going to turn to our next presenter.
Maybe. That's the answer. Maybe.
I'll
think about it.
Yeah.
All right, Dr. Fry, we have, thank you, judges, for all your feedback. Dr. Fry, the floor is yours. And we can't hear you at the moment.
That's because my mic was off. Hi, everyone. Thanks for coming. I am a PGY4. I'm a first-year cardiology fellow at Stony Brook University Hospital. Today, I'll be talking about my research proposal about post-intensive care syndrome in patients admitted to the CCU. Next slide, please. So just for some background, post-intensive care syndrome, it's a disorder leading to physical, emotional, and cognitive impairment during or after an intensive care unit admission. And so it can be manifested in one of 4 domains. So there's the physical impairment, either with a critical illness neuropathy, myopathy, muscle wasting and weakness, decreased mobility. There's cognitive impairment, issues with memory, attention, executive function, as well as problems with mental health, specifically anxiety, depression, and post-traumatic stress disorder. There's also an element of the experience of the family members, anxiety, depression, as well among them, which will not be the focus of what I'm talking about today, but is another factor to consider. Next slide. So some risk factors that we do know that lead to this after patients come out of the ICU is sepsis, multi-organ failure, a longer duration of mechanical ventilation, use of neuromuscular blockade, delirium, metabolic abnormalities such as hyper and hypoglycemia, pre-existing psychiatric disorders such as anxiety, depression, known PTSD as well. All of those will increase the risk. A lot of this is fairly well characterized in other disease settings and other ICUs, such as the medical ICU, surgical and neurological ICUs. Based on my review of the literature, there isn't much out there published about the nature of this on patients admitted to cardiac ICUs. And so given their unique disease states and the therapeutic interventions that they receive, that are not commonly performed in other ICUs, it could lead to differences in presentation. Next slide. So the objectives of this project, it's to describe the prevalence and characteristics of post-intensive care syndrome in a cohort of patients admitted to the ICU, with the goal of identifying specific ICU and patient-related factors that are associated with the development of post-intensive care syndrome. I hypothesize that CCU-specific factors such as cardiogenic shock, ventricular arrhythmias, as well as certain interventions such as the use of mechanical support and cardioversion will significantly increase the risk of the development of post-intensive care syndrome. Next slide, please. So the patient population that I'll be including is basically anyone over 18 years of age admitted to the CCU at Stony Brook for a primary cardiac problem. Patients will be excluded if they are admitted to the CCU for a non-cardiac primary diagnosis, such as if they happen to be bound for the MICU, but the MICU is full, and so they end up in the CCU because of bed availability. And also just because of the way that I'll be collecting data, which I will describe, patients with pre-existing severe dementia who are unable to provide a history, who are unable to provide reasonable information for the way that I'll be collecting data, they will be excluded as well. Next slide. So the way that this will be done is after the patients are discharged, they will be kept track of in 3 months afterward. They will be contacted over the phone, and a number of questionnaires will be administered at that time. The following have been used in other studies, specifically looking at post-intensive care syndrome and are often used in post-ICU clinics. So the hospital anxiety and depression scale to assess for anxiety and depression, the post-traumatic symptom scale to assess for symptoms of PTSD. The Barthel Index assesses physical functioning, such as independence in ADLs, IADL, strength, ability to get around, and then a short memory questionnaire. There are a couple of ways to go about this. The first is to ask the patient, use a questionnaire asking the patient. There are things that are validated over the phone, similar to the way a MOCA would be done in person, or ask a caregiver their observations of their loved one's memory and cognitive ability. And PICS will be defined as the presence of a new deficit in any of the 3 domains. That would be cognitive, physical, or psychological. Next slide. And so the significance of this project being that patients admitted to the CCU are likely at a high risk of developing PICS following hospital discharge, and appropriately identified patients can be referred to a post-ICU clinic designed specifically for patients with cardiac problems for integrative care. And if anything is identified, any problems are identified, either cognitive, psychological, or physical impairments, these patients can be referred to the appropriate specialists to receive ongoing care. for their post-ICU syndrome to improve their functional status and their symptoms as they have recovered from their acute illness in the cardiac setting. Thank you.
Excellent. Thank you very much for keeping to time. I will hand things over to Dr. Katz to kick things off. Jason, I know this has been an important area of interest for you.
It is, and I'm far from an expert, Jesse. I think you did a fantastic job, and I applaud you because I think this is a really important area for investigation, right? We oftentimes think about cardiac ICU patients and we sort of define their entire experience within the confines of the ICU, but really it's part of a larger journey. And many of these patients are readmitted or die shortly after being discharged from a hospital, particularly among high-risk populations. So I think this is great. What I like about what you did is that you sort of you're challenging, a notion that exists within other ICU settings. You're trying to define the problem, and then you've even given us an idea about how you might address it and investigate further by potentially developing post-ICU clinics, et cetera. I guess my question is more, again, a sort of a practical question regarding how you might set this up. Two questions, really. One is the intent to enroll these patients before they leave the ICU? Because obviously it becomes much more challenging to reach out and identify enrolled patients once they've left the confines of the ICU, or at least your institution. And then give me a sense from a practical perspective, all these different survey instruments, how long will they take? What do you think is the chances that you're going to get people to respond and follow up? I'm sure you've thought about the likelihood of capturing these patients and how hard that might be.
Yeah, so the intention is definitely to enroll these patients and talk to them about it so they can expect a phone call and consent to the whole process before they leave the ICU or the hospital. We keep close track of especially our patients who come in with STEMIs and our patients who come in with cardiogenic shock, which is going to be a bigger focus of people I'm trying to target. We have a shock team, and everyone is very well documented and watched and checked on every day. So at some point we'll be able to go in and talk to them about what our intention is and get them to agree to talk with us down the line. As far as the
Great.
duration, I don't expect everyone is going to be interested, and then the people who say that they're interested may, just not be available to speak, maybe lost to our follow-up, not pick up the phone. It's probably difficult to predict how many of those people will be lost to follow up in the study, but talking to them beforehand, getting good contact information and backup phone numbers, I think will be helpful.
But he's asking you how long they're going to have to be on the phone for these 4 studies.
It could be probably up to a half hour.
Dr. Hollenberg, I'll let you take over from there if anything else you have to add.
Before Hollenberg takes over, I would say that what the best thing was is he was trying to give me a hard time. I saw the mouth moving, but he was on mute the whole time. So none of us heard it. All right, your turn, Steve.
I'm not very smart. What I was going to say is don't let him fool you with this I'm just a country doc thing. I don't know anything about this. Right before, there's a poker term for that. That's called sandbagging. I don't know anything about this. And then he gives you this great summary and great questions. So I think this is an important thing too. I always agree with Jason, except when I don't. So I have a suggestion and a question. So maybe I'll start with the question. You're defining this as a new deficit. So how do you know it's new?
So I'll have to. The way that I'll go about it is by asking them in their impression if it's new subjectively.
So that kind of gets into my second point. I think the family part is really important, and I don't know. You guys probably know Will Flannery as Dr. Glaucomflecken. He had a cardiac arrest. He gave a talk at Chest, and his wife came, and she made the point that she's involved in this arrest too. She wasn't the person who arrested, but it's just as traumatic for her. So while this may not get, so I think if you're going to get to this family, you're going to look at post-arrest syndrome. I think you ought to figure out some way to get information about how the family is reacting. That may or not play into whether the patient has post-arrest syndrome, but it's a really good opportunity to try to sort out how the family is dealing with this. And I'll leave it to Erin.
Thank you.
Yeah, I actually was asked the same question about how do you define new, and I wonder, I don't know this because I don't know this field, but are there validated assessment tools where you could get that information from baseline information from a family member, and then potentially as a follow-up, so at least you could have a delta from from the same person, because I suspect with a lot of these patients you won't be able to get a good baseline from them. So, but anyway, I thought again, it's super important. It seems very feasible to me to do, and I think it was really well presented too, very clear.
Thank you.
And have you thought about any other endpoints that you might include? For example, I noticed not on your list was length of ICU stay, or duration of mechanical ventilation, which could be very strongly associated with PICS.
That is true. In my presentation, I was trying to focus more specifically on things that more uniquely are associated with being in a CCU as far as my focus. But I'll include all of that in my analysis to hopefully corroborate what has been seen in studies that have been done in patients in a medical ICU as well.
Yeah, you might want to think about grabbing a frailty index while they're in the hospital as sort of an integrative sense of where they started.
Okay, I'll look into that. Thank you.
Yeah, and there are some very simple tools that can be used inpatient as well for frailty. All right, thank you very much. We will move to our third and final presentation, Dr. Harmon.
Hello, everyone. Alexandra, I apologize in advance for the number of advancements I'll have you do with the animations that I'm going. So
No problem.
So hello, everyone. My name is David Harmon. I'm a general cardiology fellow at the Mayo Clinic. I'm here to present my idea, the AI meets the cardiac ICU, an AI ECG monitoring system for serum potassium to improve patient care and comfort while decreasing cost. Next. So let me describe a situation that's probably familiar with all of you. A patient comes into the cardiac ICU, they have severe hyperkalemia, their potassium is 7. Next. And then you start the treatment, you say, let's get a serum potassium in 2 hours, make sure that the patient's safe and that everything's going in the right direction. Next. And then obviously you run into every complication possible. The patient's a hard stick. They had to get stuck twice for their first lab draw. Immediately after you begin treatment for this hyperkalemia, there's a code 2 doors down and you're busy there for the next few hours. Mid-code, you get a call from the lab. The potassium is hemolyzed. Would you like a redraw? Something probably familiar to all of us. And so then you're saying, okay, get the lab tech, go back to that room, stick the patient 2 or 3 more times, and you finally go through all this hassle and you get a potassium eventually after 4 hours. That's normal, 5.1. Next. And really, it's a lot of hoopla for a normal potassium whenever you're going through all of this. Next. So how big is this problem? How bad is this problem? So in the ICU, we have done some studies at our own institution, next, that show that dyskalemia occurs, hypo and hyperkalemia, in greater than 15% of patients in the cardiac intensive care unit. And dyskalemia has clearly been associated with in-hospital mortality. We've also used an AI algorithm that has looked at 12-lead ECGs collected during these CICU stays, and we've shown that hyperkalemia actually has an additive value to increase mortality risk, especially when you have an AI ECG that is additively positive for hyperkalemia. Next. So how do we solve this problem? Well, we have a plan, and yes, it involves artificial intelligence. So next. At the Mayo Clinic, we've developed a convolutional neural network that can look at a 12-lead ECG and can determine dyskalemia with very good accuracy. Next. We have similarly adapted this algorithm to portable and limited lead devices, such as the Cardia AliveCore device, as you see here, which uses 6 leads that can also determine serum potassium with good accuracy. Next. So in this study, we would like to take this technology that has not previously been applied in a critical care environment in a prospective fashion, and we'd like to validate this algorithm to show that it can accurately rule out clinically significant dyskalemias, that we could potentially estimate how many blood draws are unnecessary. How many times are we drawing normal serum potassiums that could be accurately estimated by AI ECG? And then finally, we'd like to look at the predictive overall risk stratification from this AI. Are we able to tell things beyond what we can see? Can we tell which patients are at higher risk of a potassium-related complication than others? Next. How much time do you think this takes? I think that's a big question that is always asked, especially when you're in the fast-paced environment. And it's almost instantaneous. Once a 12-lead ECG has been collected on these patients and it's in the GE Muse system, the AI can actually run on the ECG and give us a result within a matter of 30 seconds or so. Now you're asking, well, the laboratory tech was the first one running room to room. Now you're just sending an ECG tech room to room. Next. Well, we've thought about this as well, and every patient in the cardiac ICU, at least 90% of patients, are on continuous telemetry monitoring that has 24/7 ECG. And we imagine that if we have adapted this from a 12-lead system to a 6-lead portable system, we could easily adapt this from the 6-lead portable system then to a telemetry 6-lead system in the cardiac ICU. Next. So in this validation study, next. We'd like to enroll cardiac ICU patients at risk or with dyskilemia, 2 to 3 patients per week over the course of a year. And every time a patient has a serum potassium drawn, they will get a research 12-lead ECG collected. Many of these patients will have more than 2 serum potassiums checked daily. And then we'll simultaneously look at the telemetry ECG data at the time of the laboratory draw. Next. Our analysis will include performance of these AI ECG modalities. Do each of these effectively rule out clinically significant dyskilemia? And then looking at the laboratory utilization, how many less lab draws could we have in the cardiac intensive care unit if we relied solely on AI ECG technology? And then we'd actually survey the patients and say, how would they feel if they could reduce their blood draws, reduce their sticks by half in the cardiac ICU? And then finally, we'd look at outcomes. Can we predict patient mortality? Can we predict dyskilemia-related complications from these algorithms accurately, both on the 12-lead and on the telemetry AI ECG? Next. So in summary, this validation study is a necessary next step before applying AI-guided care in the real world, particularly in critically ill patients. Successful validation would create a pathway for a randomized clinical trial, which could lead to practice change next, and probably next twice. Especially if we show that AI can function accurately in real time, providing data, can decrease the use of cost and of phlebotomy, and increase patient comfort, and also increase individualized risk stratification. Now, obviously, the parts that go into this project will need a viable CCU environment with willing patients to participate. We'll need licenses to telemetry devices so we're able to download the ECG data in a raw format that's usable for our AI technology. And then we also will need funding for 12-lead ECGs collected at the time of laboratory values. So I'll take any questions at this time. Thank you for listening.
Thank you very much for your presentation. We will hand things over to Dr. Hollenberg, who, at least on my screen, we lost his camera. If he disappeared completely, that's all right. We'll just move on to the next critical care cardiologist. Steve?
Yes, sorry. Microsoft Teams is, I can see myself.
We can hear you, so that's
Okay.
that's fine.
Excellent. So very interesting, fascinating stuff. Anything that uses a convolutional neural network, I'm going to need my colleagues to explain to me what that is. But I have sort of a technical question and a clinical question. So you sort of used the term dyskilemia. So I want to ask, so that works. So I guess I want to ask, does it work as well on the high end as the low end, or does it work better on one end? And what do you mean by dyskilemia? Because I got to tell you, sometimes I want to know if the potassium is 3.5 or 3.6 because I'm diuresing somebody and I'm thinking that's going lower. So how good is it? How sensitive is it?
So that's an excellent question. So dyskilemia, I use that in place of hyper and hypokalemia because of the time constraint. So we've recently validated a new algorithm. I apologize, I don't know the numbers off the top of my head. I know sensitivity, specificity are both in the 80s for this. And it can detect both when it's like outside the laboratory normal, so like lower than 3.4 or higher than 5.5. But if I remember correctly, our algorithm actually will tell you a point on like an actual serum potassium value. Will actually estimate the value for you as well. Now, I mean, this also goes with, there's quality checks that have to go in this too. And we actually have been working on this on the back end, because some patients say they have dextrocardia or say they have an existing bundle branch block. how well is it going to work? That's why this is a validation, not a randomized trial yet. But we do keep that in mind because we do want to know to the extent of to the extent of how kalemic are you one way or the other. I will say this new algorithm. So we had an old hyperkalemia algorithm that just did probability of hyperkalemia. It was 90% chance that you are higher than 5.5 or lower, and that's not as helpful. So this is actually a fairly new technology that came out actually within the last, it was presented at Heart Rhythm. So we're pretty excited
Yeah.
about it, but it has a lot of work to go.
Spoken like a true technologue. It's getting better every day. Pretty soon it will be perfect.
The next
I
version's
do
even
think you're
better,
gonna.
just wait.
I mean, I think the idea of continuous EKGs is great because you aren't going to get 12 lead EKGs every 10 minutes for a 4-day ICU admission, but you're going to have to look at artifact there. So, I would suggest that you might want to even think about that while you're collecting data, because yes, you have a fixed point, but remember, the EKG, the patient's moving, all that, and you're going to have to figure out how this thing is going to filter out artifact.
Without going into too much detail, I actually was reading a recent study that I think is about to come out in PJ Digital Medicine that has looked at that, because a lot of the handheld, like the Apple Watches, the cardio devices, there's people, folks with tremors, ground noise and things, and so they're actually working on filtering these ECGs, just ECGs, not using AI, but just the ECGs, filtering it and actually decreasing that background noise. But I mean, it's a valid point. I mean, if you have,
or alternatively, sometimes you just don't get usable data.
Right.
I have to say I'm a little skeptical about this blood draw thing. If you really think you're going to be able to reduce blood draws just by not looking at potassium, that's a big lift. We get bloods for everything, and it's automated, and people want to know the creatinine, the potassium, and the this and that. So
right. And I was going to
luck.
mention there's definitely the caveat. If somebody's in renal failure, you're not just checking for a repeat blood draw for potassium alone. So
Well, it'll be good to study it. Dr. Bohula has actually been using telemetry data to evaluate another aspect in ICU patients. Dr. Bohula, any comments or questions?
Yeah, I want to commend you guys for what you've already done, because it's hard working in the space. It is hard, and dealing with artifact and dealing with all of the background that you get. We've been working on continuous telemetry and trying to predict VT there. But I guess I have a question for you. In the derivation of this, what patient population are you using? And I guess also along those lines, would you imagine then that if you're applying this, say, in the CCU, it'd be a different patient population? And are there any caveats that you need to think about? I didn't notice the dog.
I'm not trying to distract.
He was trying to steal your time, and
sorry.
I have one under my desk here, but he's too big for me to lift up. Otherwise, I would show you him. Yeah. So I guess what was the derivation population, and then are there patients where you couldn't apply this? So say paced rhythms, bundle branch blocks, all that kind of stuff.
So that's an excellent question. I'll try not to get too distracted, because that is my specific niche within this research, is validation, at the patient populations as a whole. So this AI algorithm for the potassium values actually was a very large all-comers data set. So no one was actually excluded. It was just paired potassiums with ECGs. But you have a very valid point, though, that a lot of our algorithms, I've worked with one that did AI ECG for amyloid, for cardiac amyloid, but it excluded surgical patients with paced rhythms. And so in the performance, we actually did some just brief data analysis on that, and it drops dramatically, as you would expect. So I think that's the big nature of why this is a validation study, because we're taking it from a general populace, folks who come in the ED who may have an orthopedic problem, but they somehow got a potassium in the ECG, who knows why, but now they're in their data set and they're actually healthy. And now you're looking at all these very sick patients. A lot of them, the things that I've been thinking about are, you're going to have some wild ST T-wave abnormalities, some interesting bundle branch blocks, temporary pacing wires. So I think we're going to find ourselves in a very rich data set that's going to be incredibly difficult to decipher. I know some.
Nice way to say it. Very
I know some groups have used like saliency mapping. So whenever because this is definitely a black box. I think that's where a lot of people get leery, is not only are we not looking at the potassium, we're saying, yeah, don't worry about it. Our computer said it's fine. And most people don't want to do that, surprisingly. But we've been looking at a lot of networks that will kind of highlight on the ECG, you know, where did the AI spend the most time? They've been doing that with other technologies like chest X-rays and pathology samples, where it kind of like creates a heat map over the areas where the computer was focusing. So in retrospect, we might collect all this data and then go back and apply, and then we'll also be able to see who may or may not be eligible. You know, we might say patients with normal sinus rhythm, you know, a young person with a cardiac arrest suspected from like long QT or something that's less, you know, like less ischemic, less, you know, infiltrative cardiomyopathy wise, like could be eligible for this type of potassium monitoring, where somebody else who's older, sicker, has surgeries may not be.
So before we see any more animals come out from Dr. Hollenberg's desk, I just want to hand things over to Dr. Katz for any additional questions.
Be quick. Thanks, Dave. Dr. Harmon, that was great. You certainly win the cool factor for the presentations today. I think that is pretty darn cool. And I think, you know, we are bombarded with a lot of information, much of which we don't tend to use in the ICU setting. The cardiac ICU is no different. And I think looking at opportunities to leverage some of the data that we're bombarded with and we get routinely would be, I think, really a viable effort, and I think worthy of investigation. And so from that standpoint, I think it's great. I would just sort of piggyback on what Steve and Erin had said. I guess one is, you know, I'm a little concerned about how often we check blood work just to measure an isolated potassium. I mean, it's very rare for me to get serum chemistries and only care about the potassium, even when patients that present with hyper or hypokalemia as their sort of primary manifestation. So I'm a little curious about that, and getting to that epidemiologic information, I think will be kind of challenging. And then, you know, what are there is one thing that I think the sharks on Shark Tank think about, and we certainly think about here, is, you know, how to then apply this information or the knowledge that you gain to future investigation. Are there ways to leverage the same type of technology to find other electrolyte abnormalities or other things that we might be interested in determining non-invasively in the ICU?
So those are very good questions. So to go along with the first one, so it definitely, looking at this algorithm, you know, getting isolated potassium lab values is a rarity in the ICU. We chose the ICU specifically because it's such a controlled environment where there's a lot of serial blood draws that will be able to validate this well. I think in the ideal world, that, dare I say, it might go off of the ICU to some of your, you know, your general cardiology floors that also use telemetry, and you're looking at potassium more or less with somebody like a heart failure patient diuresing who's otherwise stable, or some situation like that, or somebody at home like a renal failure patient who you already know their creatinine's bad, but you're just trying to see, do they have hyperkalemia, hypokalemia, and you know, will that influence their dialysis schedule? So I think the nature of this is that the CICU has a huge data rich population where we can do this and validate it. Will it find its home in the CCU? There's a chance, I mean, given all the very valid reasons mentioned, potentially not. I have seen a few.
Dr. Harmon, I'm going to give you just 15 seconds for the last part of the question.
There are other teams in other places doing other electrolytes with AI ECG. So not us, but I have seen it.
All right, thank you all for your excellent presentations. I am going to ask our three judges to go into seclusion to discuss your presentations, and then come back with a winner to represent Critical Care Cardiology at the ACC 2024, and also give all of you some feedback on your presentations. So we'll see you all back, and they only have 5 minutes. So I'm going to go ahead and open things up to the floor to see if we have any questions from our audience that have come in. I think as we give people a chance to ask questions, I'll just say that you really should be proud of the work you've already put into developing these proposals. It is reflective of the field of critical care cardiology that we have everything from a very detailed evaluation of invasively obtained data with a fairly focused parameter that we might translate into improving care, to using big data to understand how we can better apply AI to this population where we have an enormous amount of data that flows at us in the ICU, to thinking about the long-term consequences of critical care and what we do in our cardiac ICUs, and think well beyond the hospital stay. And it really reflects the full gamut of how we care for these patients. So we really appreciate the work you've put in. I don't see any questions in the chat so far. Maybe I'll ask Dr. Fry just to start us out and comment a little bit more on how you might address issues related to diversity, equity, and inclusion in this population, and really your ability to deliver the questionnaire to the entirety of the CICU population, where it's possible that your ability to recontact them may be related to social determinants that also are linked to their health.
Thank you. That's a good question. So I think really one of the major things is going to be engaging with them and also engaging with their family and figuring out what really is the best way to get in touch with them. So for some people, is it over the phone? For some people, is it over email? All of this is done not in person. We don't have a post-ICU clinic to invite them back to within the Department of Cardiology. So it does have to involve reaching out. So it would have to be like figuring out what their just what their preferred method of contact is, and getting backups and getting their family members, their caregivers involved to help us figure out how to get in touch. If it's better to get in touch with their family members as well, then I'll start there.
Yeah, and I think it definitely will be, I'm glad you've thought about it. And I think if you're our winner, that it will be important to think about how you can support access to and acquisition of data across the whole
spectrum.
There is a question in the chat from Dr. Lee at University of Miami for Blarina. Do you think that DPDT can be used for patients on mechanical circulatory support? Or severe valvular disease or RV failure? Maybe I'll ask you just to focus on the MCS. Is it going to be valuable in that group of patients? I'll ask you to come off mute.
Sorry about that. So it could be used in both spontaneously breathing patients and those mechanically ventilated. Given the intrathoracic or the variable intrathoracic pressures, they'll change both PPV and SVV. So not only will the SVV be the same, or I guess won't be it won't be like an absolute change, but all of the DP over DT will also not have a drastic change. So as long as it remains over 600, it's okay.
I think it is an important issue, as Dr. Lee also raised, valvular disease, peripheral artery disease, I think, as you mentioned as well in your presentation, that all of them have impact on all of the metrics where we're trying to estimate stroke volume based on assumed compliance in distal arteries and to infer from DPDT. So that is another important area as you mature this proposal to think about.
Okay.
All right, very good. And then for Dr. Harmon, I guess as well, picking up on Dr. Hollenberg's questions about the extent to which we really need to reliably understand where the potassium is and what the trajectory is. Have you thought about the more quantitative performance, and what initial information do you have maybe to build on that initial comment that you have, either to understand trends at least, and also to predict more refined areas of concentration?
So I guess the question, like, what What have we done so far as qualitative
Yeah, so
performance?
I guess I'd back up and say, so far it sounds that you've been able to predict the extremes,
Yes.
right?
Yes.
And
I see
I
what you're
guess,
saying.
yeah, go ahead. I think Dr. Hollenberg's question was related to the fact that so often you really need to understand trajectory within the normal range. And
Right.
is that possible with the technology from what you've developed so far?
So that's an excellent question. So the initial evaluation that we've done with this newer algorithm, it has more been an evaluation of the extremes, like you mentioned. Now we have like an earlier derivation of the algorithm that did look at predicting potassium value just throughout the whole range, going from 3 to 7 essentially, and that it could accurately do that. But then we also found some other performance bugs with it, more or less. So this algorithm, I'm not entirely sure. The big brunt of the study, though, will be seeing if we can have a good negative predictive value if we're trying to rule out clinically significant dyschemia. So then I think we'll have a lot of data on these mid-range potassiums to be able to see how accurate are we actually getting this mid-range potassium. So I think that's a very good point. That's something that we should definitely focus in on more, even more than we think about normally. So we want to roll out the extremes for sure, but then also say, can we look at the middle of this also accurately? So I think that's fantastic.
All right. Well, thank you all for your discussion while our judges were away. I am going to ask Dr. Hollenberg as our senior member of our judging team to announce our winner.
So we really thank all the presenters. It was really well presented, very interesting and great ideas. And we actually hope that all of you get to do these projects, but there can be only one winner, and we have selected Dr. Harmon's project with the AI EKG as the winner.
Congratulations, Dr. Harmon.
Wow.
We have a few minutes left if you want to add any specific comments and also final advice as this team will have Dr. Harmon representing all of us among the other Heart Tank winners. Anything you want him to think about as he refines his project for that presentation?
Yeah, I'm going to let Erin start.
Yeah, congratulations, David. Nice job, nice presentation, and congratulations to all of you for really nice presentations, for nice designs, and for being here. I guess what I would say is when you're presenting it, it sounded to me when I was listening to you talk about it that you were deeply involved in this, and but I think one of the things I might say for the next presentation is to maybe describe your role in the team. I know it looked to me like it was a big team effort, but kind of what is your expertise and what is your role, to define that a little bit more?
Sure. No, that's a very good point. It is a very large team. Yeah. So I do
as it should be for this. Yeah.
Yeah. Yeah. No, I am not an engineer by any stretch of the imagination. So we have a fantastic engineering and statistical team, and then so yeah, as a fellow, a lot of my role is the study doesn't exist yet, so it's not entirely defined, but it'll be partially with enrollment, partially with data analysis, and then partially with quality checks with everything that goes in our system too.
And Dr. Katz?
Yeah, that was great. To all of you, it was great. I was really excited about each of the presentations, and congratulations to Dr. Harmon. We noticed that you were co-authors with a couple of our friends and colleagues, Dr. Jenser and Barsness. We probably wouldn't mention that at the ACC 24 if you have any hopes of winning. But in all seriousness, I would say we really like this. I mean, again, I think the sexy part is addressing costs of care and everything, but I think really I would just sort of focus on sort of the protocol itself, some simple outcomes that you'll be studying. And again, I would let the judges know about how you can see this sort of application being not only further studied but more broadly utilized in the cardiac ICU population.
And I'll just close by saying that I'm glad you've all been able to see the warm and collegial community that we have within critical care cardiology here. Dissing the mentor is always welcome during these judging sessions. But no, we have a huge respect for all of your mentors for helping you get to this stage. And I think also as well to recognize that you all span a breadth stages in your training, and we hope very much that you will continue to work on these ideas and that you'll come back to us again with additional proposals and refined proposals and take advantage of another opportunity. So we thank all of you for your submissions, all of our audience for joining us, and especially our three judges for their expert commentary, insightful advice to all of you, and for helping to move this field of critical care cardiology forward. So I thank you all. I will open up just for Alex to see if there's any final closing comment that she has. Otherwise, we'll end the call.
Thank you, Dr. Morrow. This was fantastic and a great way to kick off our 2023 Heart Tank series. So I think that's it for tonight. If anyone listening, if you are in the interventional field, that will be our next one. We're looking at a date in September. So we will be putting out applications for that for the FITs as well as to register for that. So we look forward to that. And Dr. Harmon, congratulations. We will see you at ACC 24. And Dr. Fry and Dr. Aslanaj, congratulations to you both as well, and keep up the great work. So thank you all, and have a great
Thank you,
night.
Good evening.
Good night.
Thanks, guys.
Thank you.